Well, good afternoon or good morning, wherever you are. Just wanted to invite you back to the EMT transition course. You're actually halfway through, so kudos to you. I'm going to go through a couple more topics that are identified by the Bureau of EMS requirements, and then we'll have another quiz and we'll get you well on your way. We're going to talk just a little bit about some interesting topics, one of them being agitated delirium. We're going to talk about what is it, and as an EMT, how does this affect me? I think this is a very cool subject. I actually love dealing with psychiatric issues and issues of the sort. Now, I don't know what that says about me, and we're not going to talk about that right now, but I think this is an interesting topic. So let's see, what is agitated delirium? Well, first of all, delirium is a mental state characterized by an acute circumstance. Okay, so acute meaning sudden onset. This isn't something they deal with long term. This is something that has just happened. So they're disoriented. Now that may be that they're disoriented to who they are, they're disoriented to where they are, they're disoriented to the circumstances that they're in. They may know who they are and where they are, but they're perceiving things inappropriately. They're thinking that there's things there that are fearful that aren't. They may have a disorganized thought process, so they may be looking at things that should normally, by normal people, be perceived in one manner, and they're looking at them entirely differently. They may see things that aren't there. They may be reacting to things that you don't think is appropriate. And then they may have disturbances in speech. That may not be that they can't talk or that they can't talk effectively. It just may be that what they're saying is not appropriate. And that doesn't mean that they're being rude. It means that they're coming up with things. They're talking to you, but what they're saying is making no sense at all. Now, we can look at this and say, well, gosh, diabetics are that way. When they get low on sugar, they act that way. Yes, they do. And it is a sudden onset. Excuse me, my dog is helping me with this today, so she thinks it's her mission in life to guard the sidewalk outside. But when that state starts to involve violent behavior, that's when we're going to label this agitated delirium. So I'm going to play a video for you. I want you to watch it through. I'm not going to stop and interrupt it, but watch through the whole thing, and then we'll discuss it, and you can see. But now, this is a little bit old, and you're going to be able to tell by some of the medical maneuvers that are performed in this video that it's a little bit dated. However, it still happens today. The agitated delirium is very real. This is a real situation. I think you'll get some good stuff out of it. So let's watch. Okay. Well, I think that gives us a lot of food for thought. As EMTs, typically, we were called to situations like this for exactly this reason. When there was injury or harm inflicted by law enforcement, that's when EMTs were responded. Now, as we kind of move forward and are a little more proactive in things, typically EMS is called much earlier to try and identify possible causes and to be there in case harm has inflicted. But as you can see, a lot of these agitated delirium patients are very, very difficult to deal with, and they do have to be restrained. And unfortunately, in that process, sometimes injuries do occur. Could this have been prevented on this young man? Probably yes. Was it intentional? Absolutely not. This gentleman did pass away, did not survive this episode, and I'm sure there's a lot of things that some of these law enforcement officers wish they could redo. When this gentleman first presents, he's obviously not able to process things in a normal manner. He's fearful of someone that beat him up who isn't even there. He's not able to process that running into traffic is dangerous to him. He keeps perceiving the law enforcement as somebody that's trying to hurt him. And then he starts becoming very violent with law enforcement. As you can see, when he started biting them is when they decided to hobble him. Now, they're trying to get him ready to do something with. They can't just keep hanging out there in the middle of the street with him, so they're going to try and transport him. But as you can only imagine, this is a challenge. Transporting somebody that's in this mental state is not an easy task. So to get him ready and keep him safe and keep others safe around him, they made the option to restrain him. Now, the handcuffs behind his back were a good start. It wasn't enough. They finally went to the hobbles and finally decided, because even with the hobbles, he was starting to bite them. They couldn't even really pick him up and move him safely. And so they decided to put his hands and feet together. Now, understand, he's going to have to go in the back of a patrol car to go to jail. And that's not going to be an easy thing to do. But when he did start to bite them, one of the officers put his knee on his shoulders to keep him down so he wouldn't continue to fight and thrash. And that's what asphyxiated him and cost him his life. So what we'd like to do is to see how we can make this situation less detrimental for the patient. Okay? First of all and foremost, as always, we got to think about number one first. Now, I really struggled with this when I got into EMS because to me that sounds so selfish. But having been in EMS for a great number of years now, as selfish as it is the only smart thing to do. If you can't be safe where you're at, then you don't need to be there because two patients doesn't make it any better. The other thing we need to think about doing, we're going to talk about this a little more, is establishing a rapport with your patient. Now, I'm here to tell you this may never happen, but you should at least try. Okay? And we'll talk a little more about how to do that. Avoid any threatening actions, statements, or questions. And some things that we may perceive as just being perfectly normal, we need to step back and put ourselves in their shoes before we say or do something. Okay? So if I go over and say, "What are you doing?" that may be perceived entirely different by that person. So maybe a better way to say that would be, can you tell me what's going on? Okay. That's an opening question, and they can fill it in. You're not coming across as stern. You're coming across as compassionate. Instead of saying, tell me your name, say, my name is Cherry. Can you tell me your name? I'm being less demanding. I'm offering something in return for something, so I'm going to want this patient to think that I'm willing to meet them halfway. Understand that they're not probably going to communicate with you on a level that you can understand going into it. So anything that you get from them is a bonus. When you approach them, approach slowly, purposefully, and tell them what you're going to do before you do it. If you tell them, I'm going to take 5 steps, then take 5 steps. Don't go any further until you tell them. Maybe even count them out so they know that you're trustworthy, because they're going to doubt everything you say and do. So nice and slow. Calm the patient. This officer did a good job of that. Buddy, I'm trying to help you. Let me help you. What can I do to help you? Try and calm the patient. Let him know that you're not there to hurt him. You know, I want to help you. I'm not the enemy. You know, let me do what I can do to help you. What can I do to make you feel better? But we don't want to leave them alone unless it's unsafe for us to be there. So we want to stay with them, probably at a distance, and be with them and just keep reassuring them. Now, I wrote in here, consider the need for law enforcement. I should have maybe worded that a little stronger. Instead of considering the need for law enforcement, I should have maybe just said call law enforcement, because I think law enforcement, if they're available at all, is a huge advantage in a situation like this. Number one, you're going to need the hands. You're going to need some help. These people are very difficult to handle. Even little guys and ladies are difficult to handle in this situation. And number two, it is really good to have a witness such as law enforcement in case something comes about that there's harm done, that you did not do anything maliciously or negligent to cause that harm. Most of the time, these patients are going to need to be restrained. So if necessary, restrain them. But before you do that, you need to know what restraints you have, what's available to you, how are you going to use them, and what your protocols and policies are in using restraints. Because this is a very, very open subject for lawsuits. So make sure that you're toeing the mark on those. And then think about how we're going to transport this patient. Like we talked before, that's a biggie in transporting. I'm going to go back here just really quick here. I think I went too far. Okay. Let's talk about transporting. We talked about trying to get this gentleman into the back of a patrol car and how difficult that would be, and the dangers that it's going to present, not only to him, but to the officers getting him in and out, to him himself, to the vehicle itself. This guy obviously was not thinking beyond his own fears. So getting him into the back seat of a car was challenging. Heavens, they couldn't even get him to sit up on his bottom to sit down on the ground. So it's going to be a challenge. There is a device, and for those of you in western Iowa, and perhaps beyond, you may have heard of it. There's a device that was actually invented by the sheriff of Crawford County. His name is Tom Hogan, and it's called the Hogan chair. And it's a chair, but it operates, it moves like a furniture dolly, so you can set your patient in it. There is a strap around the waist. There are straps that go over the shoulders to hold the shoulders back, and those are actually tightened from the back of the chair. There's a platform for the patient's feet, and then the hands actually fit down in little, actually fairly good-sized PVC pipe that are cut in half, so the arms, the forearms sit down in that PVC pipe, and the leg and arms then can be Velcroed in. It's a very cool chair because you can tip it and roll it around. The patient's very secure in there. There's also a hood that can be placed over the patient's head that's made out of a mesh, so they can breathe and they can see, but if they're spitting, it can't get on anybody else. The cool thing about this chair is you can move your patient around, but when you back it into a squad, you can back it in and the back wheels actually lock into the horns of the squad right where your cot would lock in. So you can pull it into the back of the squad, lock it in, their seatbelt in, and it is very, very safe to transport them that way. So if you have access to one of those, or your local law enforcement does, that might be a very good avenue to use. In talking about restraints, you need to know what you have. There are lots of different varieties of restraints. Some are disposable restraints that you tie. Some are disposable ones with Velcro. Some are Velcro cloth restraints. There's also leather restraints. Preferably, we want to use something soft. Now, if you don't carry restraints on your squad, what could you use? Cling or rolled gauze works well, but it's difficult to get on somebody that's thrashing around. It's hard to get that around and tied securely. You can use duct tape. We laugh about it, but you know what? It's a heck of a tool, and if you've got it and you're available to use it, that's something you can consider. Now, again, you want to make sure that you're following your own protocols. The thing that we want to be careful of with duct tape or that wide 2-inch cloth medical tape, that works really nice. We just want to make sure we're not getting it too tight and we're not cutting off any circulation. So think about what your protocols are and think about what you would do in a situation, what is going to be your number one choice. Okay, so we want to engage in active listening with this person. Let them talk. You're going to learn a lot from what they have to say. It may not make much sense to you, but it's giving you a peek into how their brain is processing reality. So listen to them and then repeat some of it back. So what you're telling me is there's somebody here that you can see that you think is trying to hurt you. Is that what you're telling me? And feed it back to them and see what you get. Now, don't play into the delusions, again, but you can certainly see if you've got it right, if you're understanding correctly. Be supportive and empathetic. Tell them, buddy, I know you're scared. Okay? I know you're frightened. I understand that you see somebody there. I don't see them, but I understand that you do. Then it lets them know you're not telling them a falsehood. Now, if you play into these delusions and later on they get better, you're going to look like a fool. Because A, number one, you either lied to them, or B, you were making fun of them. So don't go that route. But you can be empathetic. You don't want to interrupt when they're talking because they perceive that as you trying to be in control. Now, for we girls, that's a bit of a problem, but let them talk. They're going to learn from that. And then respect their territory. Now, all of us have zones around us that we're comfortable with certain people in. Okay, now, if you've got somebody that you're very, very close to, you have no problem with them walking up and getting real close to you and putting their arm around you or touching you. It is not uncomfortable at all. But if a stranger would do that same thing, that's creepy. Okay? And if you get to watching, you'll have a space, and you'll have a parameter around that space that subconsciously it's okay for close friends to come this close. Okay, it's okay for acquaintances to come this close, but if they get any closer, it's weird. Okay, you feel uncomfortable. You've got a parameter set up that is okay for strangers. And if you come into that, a stranger comes into that parameter, it is uncomfortable, and the first thing you do is back up. So these people have those territories as well, but they're magnified. So that area where it's okay for a stranger to come in might be 2 feet, maybe 3 feet. For these guys, it might be 20 or 30 feet. So as you start to approach them, you're going to notice that they change dispositions with you. You may be okay here, you take 2 more steps, and now they're freaking out. And if you take 2 steps back, they're okay again. So watch for those territories, or those zones around them, and respect them if you can. Obviously, you don't want to leave them alone, but you don't want to go charging in and try and get right up close and give them the old group hug thing, because it isn't going to work on these people. The other thing with territory is they do not like to be touched. When they're in this state of mind, physical touch is not a healing thing, it's scary. So with a lot of our patients, sometimes, a pat on the hand, a pat on the shoulder is therapeutic, but it is not going to be for these guys. So make sure that you limit that and don't go there with them. Okay? So again, don't leave them alone unless you have to. Don't play into their delirium. By all means, do not underestimate their strength or their abilities. I have been involved in situations with one gal who was actually in agitated delirium, and I bet she didn't weigh 115 pounds. We actually injected her with tranquilizing medication in the ER at the 4 times the adult strength before we got any effect on her whatsoever. One of my partners in the field tried to intubate a patient who was on alcohol and drugs and got in a situation where he needed to be intubated. And we gave him all the drugs we had in our drug bag, and nothing would sedate him enough to do that. So this mental state can override a lot of things. Certainly can override, if it can override tranquilizers, they're going to be like superhuman strength. So watch for that. The other thing we need to do is communicate with other responders. When you decide that you're going to take this person down with the hopes of restraining them or getting them into a vehicle, you need to make sure that you have a plan that is going to be able to be executed smoothly and well. Because if you botch it, that's when people get hurt. So communicate with the other responders. Don't start that plan until you have enough help on hand. If you think minimum of 5, you need at least 1 person for each extremity and 1 person for the head, bare minimum. Now, more than that may cause, what do I want to call it, confusion, too many cooks in one pot. But certainly you are going to have people to open doors, people to take care of situations like that. So make sure you have enough people. And think beyond the moment. Not only we got to take him down, but we got to take him down. What are we going to do with him when we get him down? We're going to put the restraints on. Okay, where are they? Who's got them? Who's going to be in control of those? Because if you've got 5 people holding this gentleman down, obviously you need somebody else to put the restraints on. You obviously need to get the restraints. You need to look at them. You don't use these rascals every day. So look at them and decide which one goes to the arms, which one goes to the legs. And how do we do these? How do we use them? Because I can't tell you how many times I've seen restraints put on that had to be taken off and put on again correctly later. So get it once. Okay. Think beyond that moment. Where are we going to put this patient, and then where are we going to take them? So be prepared for that move before you make it. And then don't stereotype your patient. Just because your patient is not acting normally doesn't make him a drug addict. Okay, now you notice the cop in this video. First question he asked was, how much crack have you smoked? Well, quite honestly, I don't know what this guy's issue was, but he could have had a head injury. He could have had a medical issue. He could have had a seizure. There's 1,000 things that maybe could have made him a stroke, a brain bleed, yes, a brain bleed. So don't second guess him, okay, and don't stereotype. Now this guy had no shirt on, but he had jeans and tennis shoes on. He didn't appear, granted it was dark and I wasn't there, but he didn't appear to be grungy and gross and smelly. I mean, he was clean shaven. He had normal clothes on. He didn't appear to be very dirty and gross. So look at your patient. How they appear is going to give you a window into maybe what's going on. If you've got a gentleman that's in dress slacks and dress shoes and a dress shirt, you may have a different perception of him than somebody that's grungy, dirty, gross, and smells bad. But that person that's dungy, I can't talk today, that's gross and smells bad, may be a professional that has had something happen and he's been out there for 3 or 4 days wallowing around trying to live through this mental crisis that he's now in. It may not be that he's anything bad at all. He may not be a street person or a homeless person. He just might smell like one. So don't stereotype, but do take a look at what they appear. Okay. If they've got professional clothes on, take a note of that. If they've got attire on and body hygiene, long straggly beard, long straggly hair, clothes that have obviously been worn way longer than they should have, and layers of tattered stuff, maybe this is a homeless person, which can lead you to an entirely different set of possibilities for the onset of this disease or of this situation. So don't stereotype, but do be observant. Okay? Always remember, and I can't say this enough, keep yourself safe. Don't provoke your patient unnecessarily. You should, if at all possible, let them be in their comfort zone, if there is one, with your distance and stuff until you decide to move in and take him down. And then make it quick and execute it well. Call law enforcement. Coordinate your movements. Okay? One person on each limb, one person at the head. One thing you can do is somebody that's talking to the patient, there is maybe set up a code word. So when I say, that sure is a nice blue shirt you have on, blue shirt is the code word, so all of the parties know to move in. Now those parties should kind of surround him at a distance so he's not concerned. So when they move in all at once, each grab their assigned appendage, limb, and they can take him gently to the ground. Okay. Get him sitting up as soon as safely possible. These law enforcement officers in the video tried that. The patient didn't cooperate. But when they tried to hobble him, he started biting one of the officers. That officer put his knee on the shoulder, in between the shoulder blades of this patient, to keep him down so that they could safely get him hobbled, which caused the asphyxiation and ultimate cardiac arrest. So be gentle and slow moving. Try to appear trustworthy. You may not ever get there, but at least try. And be effective and thorough. Remember, airways are volatile. If your patient can't breathe, you aren't going to have a patient for very long. Okay? Our goal is to do no harm. We don't want to harm these patients. We want to help them. Unfortunately, in this situation, the patients too often end up injured. And sometimes there's things happen. I'm not saying it's always our fault. But if we can plan in advance to limit those injuries, that would be great, because our goal is not to harm anyone. If there are substances or chemicals around that you think might have attributed to this patient's mental state, take those in with you, and there's oftentimes tests and things that they can do to see if that's a contributing factor. Alrighty, let's move on to blast injuries. EMS personnel must, hold on here. All right, we're going to talk a little bit about blast injuries. Now, I know a large amount of you are firefighters as well as EMTs, and my hat's off to you for that. So a lot of this might be a little bit of over review for you guys, but we're going to look at it from the EMS point of view, not strictly from a firefighter point of view, and talk about blast injuries and how we're going to respond as EMTs to that. Obviously, blast sites are dangerous, and we've got to be alert and conscious for the hazards that are there even after the blast is over. So we're going to talk about some of those dangers, and we're going to also talk about the process of the blast and the injuries that can be caused by that. So some of the hazards coming into a blast scene would be secondary device explosions. And these can range from 22 shells that are sitting on the counter to paint cans to propane tanks, things that may be secondary bombs that are placed in there if you're looking at a terrorist act, and down power lines, which or loose wiring connections that can in turn cause some explosions to go off, detonations. The other thing we have to look at is fire. The fire and the heat that's involved with that can be caused by the initial explosion. Environmental exposures, so that can be superheated air, can be the heat from the exposure, can be the particulates that are in the air. That could be a certain avenue. The other thing we can look at is if this happens in the dead of winter, you may be looking at cold, much as we don't think about that. Or if you've got certain tanks that are, say you've got a nitrous oxide tank that's there is now leaking. You've got super cold air coming into that situation, which may certainly be an environmental exposure. And then structural collapse, which brings on a whole new set of quagmire for us to deal with. So let's look at this. There's 4 different forces of energy that we're going to deal with in a blast explosion. So the first one, we call it the primary, is that wall of air, that big blast of wind that comes up. And you're going to feel this more than see it. But if you look at the second picture there, shows a very spry young woman sprinting along at a rapid rate of 22 feet per second. Right behind her is that primary energy source, or that wall of air coming at her at 26,000 feet per second. So there is no option to outrun this. It's very powerful. Air, as you can see with hurricanes and winds and things like that, air is very, very powerful, almost as powerful as water, and can cause a great amount of damage. So when you're looking at wind that's traveling at that rate of speed, it can cause a great amount of damage. A great amount of force and energy is behind that. Secondary energy force that we deal with is the flying debris. Okay, those projectiles and pieces of stuff that are going to be coming through the air. They don't travel as fast as that wall of air because there's more resistance. But they're coming right behind it with, again, the same amount of force. Whatever amount of force is causing that wind to go 26,000 feet per second is throwing this debris at the same rate. So as these things impact your patient, you're going to see all kinds of injuries that most certainly can be life-threatening or life-ending. The third energy force that we deal with is called the tertiary, or that displacement. So the wall of air hits, then the flying debris hit, and when both of those hit, the effect that's going to happen is your body, the patient's body, is going to be displaced. So they're standing there, that wall of air and the debris hit, and it's going to move them. So they're going to get, from that flying debris, an impact, which is going to move them out of the way. So we're going to have an impact to the part of their body that's facing the explosion, and then it's going to pick them up or move them, and it will move them until something stops that energy. So it will push that patient until they either hit the ground, hit an object, hit a wall, something. So you now have double impact there. You've got the energy force that started to move them, and you've got the energy force that stops that movement. So this is kind of a double whammy there. And then the fourth energy force that we're going to deal with, now your patient has been impacted, moved, impacted again when they stopped, and now the building collapses on them, or the structural collapse on them, which causes yet more damage and impact and energy force that the body has to deal with. So let's look at these one at a time. Okay, that primary injury is a very severe change in atmospheric pressure. Okay, so we've got one atmospheric pressure, and all of a sudden this overpressurized force of air hits us. And one of the biggest injuries that we see from this, or I shouldn't say biggest, most common, is the eardrum rupture. That little tympanic membrane that goes over the ear will rupture. Now, how does this impact us as EMS? It's not life-threatening. No, it usually isn't. But the impact that it's going to have is we're trained to go in and start hollering, asking, can you hear me? Can you hear me? If your patient has both eardrums blown out, the answer to that is going to be no, they can't hear you. So you're going to have to be very observant and super thorough when you are looking for patients and survivors of a blast injury, because they may not be able to hear you, and you may call out to them and not get any response back. That does not necessarily mean there's no patient there. Other things that can happen are pulmonary damage, damage to the lungs. The lungs are air-filled, and so when that pressure change hits very suddenly like that, that can seriously damage the lungs. Can collapse a lung, can overinflate a lung, depending on several different situations, what the patient's doing at the time. So we can look at collapsed lungs. Now, I always thought for a long time that a collapsed lung was a collapsed lung. Something hit, the lung collapsed like a balloon popping, and it was collapsed. But what I have found out throughout the years is a collapsed lung oftentimes collapses a little bit. And then as you continue your care and you're taking care of this patient en route, that collapsed lung becomes worse and worse. And you may start out with a small issue that potential becomes worse as air leaks outside the lung and starts to fill that space outside of the lung. Then the lung is no longer able to inflate. And each time the patient takes a breath, more air seeps to the outside. And so over a period of time, the air that's taking up that space outside of the lung, where the lung should be but isn't, that air pocket becomes bigger, which causes your lung, the part of your lung that can inflate, to become smaller. So over a period of time, this collapsed lung progressively gets worse. Now, if you listen to lung sounds one time on your patient and you don't listen again, you're going to miss it. So look at your patient. If you're looking at a blast injury, you need to check lung sounds. You need to check them every time you do a set of vitals. Okay? So looking for lung damage. Other things that can happen are, when we get something that impacts something severely, we've got tissue damage, the one thing that happens is swelling. So if we've got tissue damage in the lung area, we're going to see swelling, and that swelling is going to present as fluid in the lungs, which is rather serious. So again, listen to your lung sounds. Air embolization. This is air because of that drastic change in pressure. You've all heard, when divers surface too quickly, they get cramps, they get air bubbles that build up in their veins. Well, the reason that happens is because that pressure changes too quickly, the atmospheric pressure. Exactly like it does in a blast injury, that pressure changes too quickly, and so it can produce air bubbles even in the bloodstream. One of the other big dangers is the hollow organ injury. So we're looking at colon, stomach, lungs. Some of those hollow organs that can suffer damage either by being collapsed or rupture of those organs. So we'll talk about those in just a little bit. But secondary. Because of that flying debris, they're kind of like little missiles, and it could be anything. Are going to come flying at you, and it's just like 1,000 little missiles or pieces of shrapnel. So we're going to get that penetrating trauma, and that we're going to have to look at just like we would a shotgun wound. It's going to come in. Did it come out? Is there an exit wound? Is it still in there? What was it? How big was it? Where did it come? What was the angle? Looking at those things, because that can cause all kinds of things from lung injury to internal bleeding to tissue damage and swelling to long-term infection, things like that. So we're looking at that penetrating trauma, and not just one. If we have a gunshot wound, we can maybe map that out, but with these blast injuries, you may have dozens or hundreds of those types of wounds. Fragmentation injuries, so when a penetrating object hits, if it's big, or depending on what it's made out of, it may fragment once it hits the body. So you may have one thing that penetrates, and then as it goes through the body, it breaks apart and goes in several different directions. And then blood trauma, things that are too big to penetrate could just hit you, much like being hit by a car. That energy from the object, say the object's going 20,000 feet per second, and when it hits your body, it can't penetrate through, so it stops. But the energy behind that keeps going through the body. And so it's going to cause a lot of damage and throw those organs inside the body around. This is where we get a lot of those tears inside the body and swelling from those. The tertiary is the displacement of the victim. And again, depending on where they are displaced to, if they hit the ground or another large solid object, then we're looking at blunt force trauma. And again, like we talked about, you've got the force hitting their body on one side and pushing them into something else until it stops, and yet that energy continues through. So they're getting blunt trauma in multiple sequential forces. So this isn't one injury. It's just boom, boom, boom. And they get it again. So we're looking at penetrating trauma if they're pushed into something, something that's not large. If it's something small, it will penetrate through their body. Looking at fractures. We're looking at traumatic amputations in situations like this. If you've got a patient that's part in and part out, it may take off a limb, pushing most of the body in one direction and leaving a limb, or taking a limb off and leaving the body. And then the quaternary, and that's that building collapse, that structural collapse. Once the main part of the explosion is over, then we're going to be finding crush injuries. Those patients that are under the debris and can't get out. Some of those crush injuries can result in amputations. They can result in vascular damage. But what you see with crush injuries is your patient's fine, they're talking to you, you lift off whatever was on top of them, and all of a sudden those vessels that were lacerated are now no longer compressed. The weight comes off of them, they start to bleed, and your patient dies or loses consciousness, because now, while the object was laying on them, their body was able to keep blood pumping to their brain and their heart and their lungs. Once we lift it off, the blood rushes down to those damaged areas, leaks out, and our blood pressure goes to the toilet. You're also dealing with burns. Remember, anything over 10% of the body surface area is considered a serious burn. And then look at the location. Is it around their face? Is it in their upper chest? Is it impeding their airway? Asphyxia, which is suffocation. That can happen by many different reasons. If they've got something crushing to their chest so they can't breathe. If they're in an atmosphere that has no oxygen in it, that would, well, they're able to breathe, but they're not getting oxygen. Or, are they underwater? Is their face and head underwater? Or in a fluid type situation? We have to look at toxic exposures. We've all learned as little kids, there's a fire, you get on your knees and you crawl out to stay out of the toxic gases. Well, oftentimes in these blast injuries, the patients are in situations they can't get out, and the entire atmosphere is full of toxic substances in the other, whether it's particulates or gases, whether it's superheated air, whether it's just simply the dust and the, typically grain bin dust comes to mind right off the bat to me, because we deal with it so much here. And so you're looking at a lot of things in the air. Now you may have canisters, you may have containers that were once sealed that now aren't, that are going to add to this toxic exposure issue. So think about what you're going into and what may potentially have been stored in that area before you walk into it, so you've got a little heads up on that. And then make sure it's safe for you to be there. And then if you've got patients that have chronic illnesses, say that they have asthma, they have COPD, they have congestive heart failure, those types of issues, or they're just getting over pneumonia or whatever. I didn't mean that to sound that way. Whatever. This situation is just going to skyrocket whatever issue they're dealing with right through the roof. So you may be looking at a patient now that is not only injured, but really, really sick as well. Here's a little x-ray that I found I thought was quite interesting. It's a picture of a patient with two femurs. You can see they're both broken, spiral fractures. And so this patient was actually spun around or was in the process of turning when this force hit him. They've got pins in those femurs. That's the long white strips going down. But if you look closely, you can see nuts and bolts that were actually impaled into the meaty flesh of this patient's thigh from the force of the explosion. So if you can imagine how much force it would take to impale that many bolts, I mean not bolts, nuts, which are round and fairly smooth. I mean there's nothing really dangerous and penetrating about a nut, but they are actually impaled right down into his flesh. So a lot of force behind that to make that happen. Okay, so some things that we're going to look at in our patients. Okay, lung injuries. Most of the time when you get to a patient that's going to have lung injuries, they're going to be experiencing some signs and symptoms of those injuries. Shortness of breath, difficulty breathing, things like that. But remember we talked about that blunt force. So if a patient is actually hit in the chest with enough force, that can cause tissue damage and can cause swelling. That's not going to happen immediately. We talked about before, collapsed lungs don't happen always immediately. So we need to watch these patients for about 48 hours just to see that they're in the clear. Because we may see a patient that appears to be okay, and within a few hours, or maybe even while they're in our care, they start to deteriorate. So just because they have good lung sounds and they're not complaining of shortness of breath does not put them in the clear. Patients with skull fractures, patients with burns over 10% of their body area, and a penetrating injury to their head or their torso tend to be at higher risk for lung injuries. Obviously, skull fractures, if the force, your skull is a pretty tough piece of bone. So if there's a force there enough to fracture a skull, probably there's a really good chance that force was very significant in the chest area as well. Severe burns, obviously because we're looking at that superheated air. If they've got those burns there, there's a good chance that there could be injury to the lungs. And then the penetrating injury also because of the force. So sometimes we're going to see these injuries from what we call petechiae, scattered petechiae, and that's that oftentimes you see it in the face of the eyes, the whites of the eyes, where those little capillaries burst. When a patient becomes hypoxic and low on oxygen, there's a process that happens where the blood kind of gets trapped in the little capillaries, and those capillaries burst because there's little what they call sphincters in the capillary beds, and there's a sphincter where the capillary begins and there's another where it ends. And as the process of hypoxia takes effect, those sphincters shut down so that the blood can be kept in the core of the body. And then as the body becomes more acidotic, the first sphincter will release and all this blood will rush into the capillary bed, but the second one has not yet released because it is not quite as acidotic yet, and so there's more pressure than that little capillary can hold, and it bursts the capillary. And we see that appear as little red, kind of spider webby marks on a person's skin and the whites of their eyes. And that's a very, very good indicator of asphyxiation or suffocation. So you'll see it from scattered petechiae around to big hemorrhages that result from that same process. So anybody that is short of breath, coughing up blood, or has chest pain, we're going to assume they have lung injuries until we know better. Okay? Now these people need oxygen. I know we've had quite a bit of talk as of late about new oxygen therapies. We used to know that oxygen never hurt anybody. And I have heard that and I have said that I don't know how many times. As of the last few years, we have had significant research that tells us differently. The research tells us that if we have a patient that does not need supplemental oxygen, and we give it to them anyway, that supplemental oxygen will form what we call free radicals in the bloodstream. And these free radicals, for the sake of a less complicated term, are kind of like little missiles, and they get in the bloodstream and they destroy brain cells. So we don't want to give oxygen to people who don't need it. However, if we've got somebody in a blast injury with any slight suspicion of lung injuries, we do not want to withhold oxygen from them. So we want to give them enough to keep them fully oxygenated. Okay. In our abdomen, our gas-filled structures, especially the colon, are the most vulnerable. And they're gas-filled, obviously, so when we have that drastic change in pressure, it's going to affect them more than others. So some things we can look at here are bowel perforations, which aren't probably life-ending right at that moment, but puts the patient at a very high risk for bleeding, very, very high risk for infection and sepsis, and that sometimes is, there's so much colon, and those little pinpoint holes in the colon are very, very hard to detect. So oftentimes we see these patients become very septic and die with gangrene or other infections. Hemorrhages we talked about. The mesenteric shear injuries, and that mesentery is the it's a layer in the peritoneum, okay, that suspends the colon from the abdomen, and so that will tear. Other things that we can see tearing are the aorta can tear away from the heart, or the heart can tear away from the aorta, which generally is a very dismal outcome for the patients. Other things that we can see are solid organ lacerations. Now, our solid organs are things like our liver, our spleen, those types of organs. And what we know from them, our kidneys are another relatively kind of solid organ. Those are very vascular structures. So when we tear or lacerate a liver or spleen, we're probably going to have a great amount of bleeding. It can be enough that it can be life-ending. So that's a big deal. And then this last one, I know you guys sitting out there reading this going, is testicular rupture. Now this happens because of a couple different things. The anatomical structure of the testicles makes it at a high risk, but also the location of it. For whatever reason, God put those that organ out where it has very little protection. And so when we get that blast injury, the testicles are really kind of out there unprotected, and so stand a high risk of being damaged. Now, understand, I know as you're sitting there, you're thinking, oh, good heavens, I can't imagine how bad that would hurt. And you think it would. But at the time, when somebody's gone through something as traumatic as an explosion, oftentimes that pain sensors don't kick in like you think they would. And I've taken care of a lot of patients that have been very badly hurt and really do not have pain associated with some of their worst injuries. They may be complaining about things that are very much less significant and really not even realizing that they're hurt in other areas. So when you guys were in your class, I know you had a patient assessment sheet that you memorized and you went down through. Otherwise, you wouldn't have got through your skills station and become EMTs. But in that skill sheet, you got a point for checking the genitalia area. And my venture is that you guys really didn't do that in class. But in this situation, you need to do that. Just take a quick check. I don't care how weird it is, take a look, because that could be detrimental. And it's a very much a reality in this situation. Okay? So anybody that's got abdominal pain, experiencing nausea or vomiting, or they're throwing up blood specifically, if they've got rectal pain, that can be that mesenteric tear, or if they've got a feeling that they constantly need to poop and their colon is empty, they've got that's an indicator that we've got some issues there, some damage there. Testicular pain, obviously, or unexplained hypovolemia. Now, hypovolemia is lack of adequate fluid in the vascular systems. Now, that can be for multiple reasons, but how are we going to recognize it? I mean, we don't actually like see in the vessels. So if you've got a patient that's hypovolemic, you're going to see them have a lower blood pressure. They'll have a higher heart rate because their heart's trying to make up for that. They'll probably have a higher respiratory rate. Their pulses may be weak. Their skin will be cool, pale, and clammy because the body will probably be in a stage of shock. And so when they get in that stage of shock, the body shuts off the blood flow to things that are not absolutely vital to life. And your skin is not vital to life. So it shuts off all the blood flow to the skin, which makes our patients appear pale, cool, and clammy. So if they've got hypovolemia and you don't know why, they're not obviously bleeding anywhere, we're going to start thinking about some abdominal injuries. Okay? These clinical signs can be subtle. That pale, cool, and clammy, we miss that a lot because it's not a huge sign. It doesn't have a neon flashing sign that says, I'm in shock. That elevated heart rate, that could be very much construed. I mean, good heavens, they just went through an explosion. Of course their heart rate's going to be up. So we have to watch that. And we need to take our vital signs and trend them. If you take a person's pulse and it's 160 and you think, well, yeah, they're pretty excited here. And you get them out of the situation, you're calming them, you're reassuring them, and the next time you take the pulse, it's 166. That's not trending in the way it should be. Okay, it's getting higher, it should be coming down. So that would be enough to take note and say, oh my, I think we need to hurry with this person. Okay, we talked about the tympanic membrane in the ear being an injury. Other things that we can look at on our ears, obviously hearing loss, but tinnitus is that constant high-pitched ringing in the ears. That can result from this. Vertigo, which is simply dizziness, unable to keep your balance, your sense of balance is all screwed up. That centers in the ears, so when you get a sudden atmospheric pressure change, that can certainly affect your vertigo. And so watch for bleeding from the canal or any other discharge from the ear. That could be an indicator that you've got an ear injury going on. Other injuries, amputations of any limb means we've had enough force there. We need to be looking at multi-system injuries. Concussions are common but easily overlooked, so make sure you talk to your patient and see if they are orientated to person, place, and thing. See if they can follow simple commands. See if they can think through a thought process effectively and quickly, or if they're having to work on that. Concussions are easily overlooked. Another sign is the nausea and vomiting can go with a severe concussion. Compartment syndrome is something that happens probably not so much while we're taking care of them, but it's something we need to be aware of in case we get called back. Compartment syndrome happens when there's an injury someplace on the body, and there is not enough blood flow beyond that injury to keep tissues alive and nerves alive. So let's say we've got a patient that has a injury to the thigh, okay? And there's some swelling there. There's quite a bit of swelling. Let's say they're in a blast injury and a big chunk of something hit them in the thigh. They've got a big, huge bruise. Didn't really break the skin, but huge bruise, very tender, no broken bones, but we've got a lot of swelling. Okay. That swelling is going to, let's say in this case, enough to pinch off the femoral artery that runs down the leg. And so now all of the tissues beyond that swelling are not going to get blood supply because the femoral artery has been occluded. And so we may run the risk, it becomes very painful and then becomes less painful as the nerves start to die. And we may run the risk of losing that entire limb just from that compartment syndrome, from an injury that really didn't appear to be that bad to begin with. Okay. And then patients that are in structural collapse, especially if they've got prolonged extrication or burns, and even or maybe a poisoning gases and such, are at risk for acute renal failure. So once the kidneys shut down, you don't have very long to get that corrected before the patient loses their life. So that renal failure can be a serious issue that we want to work with. So we don't want to dink around with these people too long. We do want to get them out as quickly as possible. Okay, so we talked about inhaled toxins. So we want to think about both, industrial situations and terrorist explosions, about the different toxins we may be walking into, and make sure that if you go in, you're prepared to do that. And if you're not prepared to do that with the correct equipment, then you need to send somebody else in that is. Eye injuries are very serious, both because of the projectile fragments and the fact that the eye is somewhat a hollow organ and can suffer some severe injuries just from the atmospheric changes. And then if we've got a expectant mommy, especially if she's in her second or third trimester, because of the location of that baby. Now normally those babies are pretty darn protected in the uterus, and they're cradled in that pelvic area, and they're pretty safe. In this situation, though, because the amniotic fluid is there, and we've got the organs of the baby to consider as well as the organs of the mommy, we may have those tears going on in the placenta. We may have rupture of that amniotic sac. We may have a lot of other issues there. If the placenta pulls away from the uterus, we may have bleeding from that, which puts the mom's life at risk. So if you've got a second or third trimester mommy there, we need to make sure that we get her in and have her monitored extensively. Alrighty, that is it for session 2. So we're going to let you complete the quiz, and then we're going to move on to session 3. It'll be your last and final session. See you shortly.